I'm not calling to order the regular meeting of the Pajaro Valley Healthcare District Hospital Corporation for Wednesday, March 26th. Rosie, if you could please give us a roll call.
Yes, Director Cox. Here. Director Gallagher.
Here.
Director Creel. Here. Director Pimentel.
Here.
Attorney.
Here. There's nothing to report out of the closed session. So I'll go now to any agenda modifications for consideration from staff. I understand that we're gonna make a change to item number 6. Is that right? 5. Number 5.
Number 5, we're gonna pull down this.
So number 5 in our consent calendar, we're gonna move from the consent calendar to discussion items. I'm wondering if we need a motion in order to do that, or if I could do that as. No. Okay. So we'll move down item number 5 to into the discussion, from the consent down to discussion. And any other agenda modifications for consideration from staff? Seeing none, I'll now open the public comment session for matters not on tonight's agenda. Any raised hands online?
No hands on line.
Okay. Anyone wish to speak, please?
Jennifer Gavin, Director of Pharmacy. So, National Doctors Day is Sunday, March the 30th, and we celebrated today with a luncheon for our providers. It was really, really nice. It was well done by the hospitality staff. Matt and Leo cooked. It was fantastic. It smelled really good. We had, I think, a total of 28 providers that came through.
Very cool.
Now, even though that number doesn't seem huge, that is all of the providers that were in-house and nearby from coastal. There wasn't anyone, I think, that didn't come by. So, so our goal, right, is to grow that. So we'll have more in-house that come in the future. But it was well attended. I think it was well done. Everyone participated. We had a good time. So thank you to our providers. They do a fantastic job. People talk about the job.
Thank you. Thank you. Anyone else wishing to speak? Public comment? Okay, seeing none, I'll close down the public comment. Oh, no, last second. No raised hands online. I'll close down the public comment for matters not on tonight's agenda. And I'll open it up for any comments from our board members. Any comments? I'll since there's no other comments, I'll just add a few comments here. Just in general, you know, I really want to applaud the work that's being done by both our local representatives, our state legislature, and then our folks over in Congress as well to you know, take action against some of the things that we're seeing come down from the federal government and impacting our local communities. And so I just want to take a moment here to acknowledge all the work that's been going on in organizing and in getting people pointed in the right directions to respond to what has been a really difficult time for so many in our community. You know, all of these different actions that are coming down are impacting people in different ways. And so I'm just really blown away by the amount of people who have come out from all different sectors and volunteered their time, made an investment in local organizations, either by volunteering or with their dollars or by providing a service and helping the community in this time. I know that there's a lot of fear going on right now. And earlier today, there was reports that Homeland Security was in our county, and thankfully those reports seem to have not been verified. And so, you know, just want to make sure that everybody continues to understand that you know, while we continue to make this, continue to make progress on making this hospital the healthcare provider that we want, and that we, that really this community deserves, that the community that we're serving is also going through a very difficult time outside the four walls of the hospital. And so I know that our administration, our C-suite does a great job of being involved in a lot of the community organizing efforts. And I just want to thank them as well for wearing multiple hats throughout the week and understanding that the service that we provide the community goes beyond the walls of the hospital and beyond the walls of our clinic and so on and so forth. So just thank you there. The other comment I wanted to make here today is, you know, the ad hoc committee for our strategic, RFP that we put out. We had hoped to come to the board today with some, with an update and with some additional action or with some movement on a couple of the proposals that we received, and we have received 4 in total, if you still remember from our initial report. We weren't ready to bring something forward, but we do want to bring something forward in either in April or in May. We're making some really great progress on the proposals that are before us and having great conversations about them. And the hope is that we'll bring something forward for the board to review sometime in the next meeting. I think that you know, the board will have something or the ad hoc committee will have a decision for the board to be made in the near future about one or multiple of our proposals that we have in front of us. And so good work being done there. Just, I know it's been a few months since the last update that we provided, but I want to make sure that you know that the work is continuing and ongoing, and that very soon we'll have something before the full board to discuss and review. Any other comments from our board before we move on to our consent calendar?
Been lately, yes.
Good.
I just have to react and thank and Magdalene and all the folks who came together today. You know, I recognize and appreciate all of our providers who are here. Also recognize the people behind the scenes who are appreciating them. So thank you for doing that. No, none of you ever asked for credit or even appreciation or you do have a sense of being part of this community. I was just talking to somebody yesterday about how special this community is, and I sometimes I think we take for granted how special this community is, and I just want to take a moment and say, not today. I'm appreciating and staying in the moment and saying thank you, and thank you to everybody who was behind the scenes helping make sure that our providers were appreciated today. So thank you for that. And I'm sure and eager to hear about it later today or board meeting, but looking forward to our state of the hospital address coming later this month or later next month.
Awesome. Okay, I'll move on now to our consent calendar. We have now 4 items on the consent agenda. Rosie, if you could read them off for us.
Yes, the first item is the minutes approval for February 26, 2025. The second item is for correspondence in the hospital or the district. And third are policies and policy summary approval for March 2025. Fourth is the Palmetto Valley Healthcare District Hospital Corporation Finance and Audit Committee Vice Chair. That is it. So this item will be moved down to this.
Okay, any questions for staff about these 4 items?
Just to comment that it's always reassuring to know we are the quote unquote highest, it's lost my rating, highest seismic rating of any facility in Santa Cruz County as a hospital. So appreciate having that in our consent item of correspondence. Reminder of the incredible assets and value of this hospital in this property.
Any other questions or comments? Okay, I'll now open up the public comment session for today's consent calendar. Anyone wishing to speak online on the consent agenda?
No hands raised online.
Okay, anyone in person wishing to speak on the consent calendar? Seeing none, I will bring it back for any closing comments and entertain a motion.
Vote to consent.
Okay, I have Pimentel and Oliver. I'll take the poll on this item. Sorry, Pimentel and Creel.
Yes.
Yep.
Sorry. Director Cox. Yes. Director Creel. Yes. Director Gallagher.
Yes.
Director Pimentel.
Yes.
And Chair.
Yes. Okay. I'll now move on to item number 5, and it's been pulled from the consent calendar to discussion. I believe that Julie, you're going to give us a presentation on this.
It's the verbal.
Okay.
So at the time we put this on the agenda, we didn't actually know the outcome of our application for a loan modification on the distressed hospital loan. Just earlier this week, we learned that this has actually been approved. So we have received loan modification for a 12-month deferral of payments on our $8.3 million hospital loan. What I was bringing forth here is the resolution, basically requesting that you delegate us the authority to execute the amendment to the security agreement. It amends the fact that we don't make payments for the next 12 months. It also amends the term of the loan. They've made it, instead of being 18-month grace period, it's now a 30-month grace period, and they actually extended out the length of it on the back end as well. We are still hopeful that, phase 2 of this process could be potential forgiveness, but that is be a separate application process. So today I'm just asking for authorization to execute the security agreement amendment.
Any questions for Julie or anyone else on staff about this? Okay. I'll open up the public comment for this item. Anyone wishing to speak on this item or online?
No hands online.
Anyone in person wishing to speak on this item? Seeing none, I'll bring it back for a motion. And any additional comments or questions?
I'll move staff recommendation with the amendment to have the final executed amendment brought back to the board. So we have that spread.
I'll second. And talk of that petition. I'll bring item back after it's fully executed.
As an accepted file or staff represents.
Director Fox.
Yes.
Director Friel.
Yes.
Director Gallagher.
Yeah.
Director Pimentel.
Yes.
Yes. Okay, now moving on to item number 6, the medical committee's report for March 2025. This is a report that we received from Dr. Christopher O'Grady in closed session. Any additional questions that from the board or staff about this, any of the medical committee's reports? Okay, seeing no questions, I'll open up for public comment on item number 6. Any hands raised online, Rosie?
No hands online.
Okay, any hands raised in person, wishing to speak on this item? Okay, seeing none, I'll close down the public comment, and I'll bring it back for a motion on item number 6.
Motion to pass this medical committee's report.
Okay, do I have a second?
Second. Director Friel and Fox, I'll take roll on this item. Director Fox. Yes. Director Friel.
Yes.
Director Gallagher.
Yeah.
Director Pimentel.
Yes.
Chair Newman.
Yes. Okay, moving on to item number 7 is the Chief Executive Officer report. Steve, whenever you're ready.
Yeah, thank you.
Ready for me, Rosie?
Okay, now there.
Right. So we do have sort of a new format, the dashboard. So it's the first test of looking at it on a big screen. So hopefully we'll be able to see it when I zoom into the individual sections. We do have some metrics on this year's dashboard that kind of overlap with some of the strategic priorities. So keeping them in separate quadrants didn't make as much sense as just sort of having them on a continuum. So we're looking at it a little bit differently going forward, and we'll see how that goes. And then I've got a number of slides and presentation on sort of how we're responding. It's kind of in general, right? How we're responding to the world outside us, and also how we're responding to some of the financial challenges that we've faced just here at the hospital over the last few months. So the new dashboard, when you're looking at it from a distance like this, is meant to look at those boxes. And so the red again means we're below our baseline target. The gray means we're kind of right at baseline, but not quite at our target yet. And the green means we're at a full performance target. If we ever get to blue, that will mean that we're at a best practice, so kind of a stretch goal. So zooming in, again, these 3 metrics are kind of in the clinical quality, patient experience, and also talent and culture area. So HCAHPS is our likelihood of recommending the hospital. We're at 74% of patients have given us a very likely to recommend the hospital, which is below our full performance target, which is the 75th percentile, but it's well above our baseline target of the 50th percentile nationally. Somewhere between those two. The next one is our safety priority index, which is our hospital acquired conditions for patients. Last year for the full year, we had 15. And on the rolling 12 months through the first 2 months of this year and the last 10 months last year, we also had 15. So we're right at the baseline. We're looking to improve that year over year. And then the next one is caregiver safety. So in 2024, we had 55 employee injuries, employee or provider injuries. And we've gone up a little. So the first 2 months of this year have seen more injuries than we did in the first 2 months of last year. So that rolling 12 months is 4 injuries higher than it was last year. So we're putting action plans in place. Our environmental care committee is looking at where those are coming from. I do think we're seeing an increase in workplace violence coming from patients and family members that is injuring nurses and staff, which is never fun, but Phyllis has done a really nice job along with HR and Margaret to put together a workplace violence prevention committee to put specific action plans around that. So we now have signage outside the door for inpatients indicating with pictures that a particular patient or perhaps even a family member in that room might be of concern and we should be ready and partner, those kinds of things. And we have the usual slips, trips, falls, the occasional needle stick that all need continuous attention. So we're trying to reduce these things by 50% year over year. These are big stretch goals, but they're really important. 2 of these metrics here for specific to talent and culture. One of them has a data point at this point, staff retention. We're still at the 84%, which is at the 75th percentile nationally. So we're pleased to be able to keep that steady. And the score survey we just completed, and we'll have results on that. I don't know if we'll have them in time for the April board meeting, but certainly by the May board meeting, we'll have results. Should probably get the results near the end of April and be able to report here at the board meeting following that. Rosie, I seem to have, how'd it go? You've done monologues. There we go. So the final 3 on the dashboard are related to clinical services and access and financial sustainability, and these sort of all overlap both those. The first one being our outpatients served, and so for that one we're green. We're ahead of our budgeted target right now. So 14,753 patients served year to date in our outpatient areas, and in our inpatient areas, inpatient acute admissions as well as observation admissions, we're just slightly ahead of where we were last year. We were at 681 at this point last year, and we're at 694 right now. So a little bit of growth, but not as much growth as we had budgeted. And that's part of where some of our financial shortfall so far has been. So that's that third one there, where Julie will get into a lot more of the details here, but we're just about 2.9 million behind budget so far this year for the first 2 months. We had anticipated a bit of a loss for the first couple of months, and we actually didn't anticipate being at break even for the year to date until I think May on our budget. So, but we've got a little bit of catch up to do to be able to get there more so than we had budgeted for. It's mostly, as Julie will show you, a revenue issue. Expenses are better than budget so far, but revenue has been off partly because of the continued catch up on the cyber attack from the end of November. Also, some of the volumes, the inpatient volumes are lower than we had anticipated. Cath lab still hasn't opened up yet. We've got plans for that to come online here soon, but not yet. Payer mix was down, particularly in February, so that was a little bit less favorable. So some of those factors, as well as January, we had challenges with CMS payments. So we're playing catch up for the next 10 months to make sure that we hit our budget. It's been a big focus of the leadership team over these first couple of months, and really since November. So the next few slides are a lot about how we're reacting not only to what's going on in Washington, DC, but also planning and being proactive about our own financial situation. So some of the federal headwinds, all this is possible. Nothing's finalized or known for sure yet, but we're looking at and keeping an eye on what's coming at us. Medi-Cal eligibility changes for sure are some things that CMS and the federal government are looking at and proposing. So more frequent eligibility checks, that comes to fruition. That always means fewer people on Medi-Cal and more people just without insurance if they have to go and fill out more paperwork or go to another office and redo their eligibility. They're just people who are going to be less likely to do that. So we'll have uninsured people. Imposing work requirements. Even if all of the Medi-Cal recipients here are working, there's still an additional filing and eligibility that people are going to have to do. It's still going to reduce the enrollments in Medi-Cal. So I think the county and I think the Alliance have their estimates of what that would mean in Santa Cruz County for fewer Medi-Cal. You know, it's in the tens, 25,000 people could potentially lose Medi-Cal access or Medi-Cal enrollment over the coming year or two. And that could, you know, pretty significant portion of that is here in our part of the county. Medi-Cal obviously doesn't pay us great, but they pay us more than nothing. So it's helpful to have those people be on Medi-Cal rather than short. And funding changes could come to the Medi-Cal and Medicaid programs as well. Per capita rates, block grants, all these things could change how the Alliance how the state gets paid, and therefore how the Alliance gets paid, and therefore how its providers like us get paid. And all of that shifts considerable cost to states, which means the states then have to make a decision. Are we gonna increase taxes so that we can pay for more, to keep paying for these things, or are we gonna have to reduce the things that we cover, reduce the number of people that we cover within the Medi-Cal system? And that impacts what we get paid and how many people are covered for the services that we're providing. So hard to say, hard to quantify at this point. We're getting, you know, sort of some more details each day. Tony, I know you sent me something earlier today, or I saw it today. That's, you know, potentially giving a little more clarity, but just for context, last year we had about 28 million in Medi-Cal revenue at our hospital, plus another almost 24 million from the QAF and DISH programs. So nearly, you know, over 50 million of the 150 million of our total revenue in 2024 came from these programs. So that's a pretty significant chunk of our revenue source. And so any, you know, appreciable impact to that is going to have a sizable impact on us, and you know, could lead to us needing to have conversations about what services do we keep providing and not providing. Not for the hospital, but for our, you know, our primary partner here in our communities, Salud Gente and other FQHCs, federally qualified health centers. Medi-Cal obviously is the primary source of revenue for them. And so challenges to their revenue streams would put more people without primary care, get sick in the emergency department, potentially without insurance, exacerbates all of those things. Some possible good news. Well, one certain good news, at least the continuing resolution, one of the good things that it did was delayed any DISH payment cuts at least through the fall. And as Julie has pointed out, we get most of our DISH payments before that happens. So we should still get the DISH payments that we are expecting and budgeted for for 2024. And we don't know what will happen after, the next cycle of Congress going through, government shutdown conversations and whatnot, if dish payment cuts will be back on the table or not. We're currently in QAF 8. I mentioned that before. QAF 9 should be announced by the state by Monday. And that would still need federal approval. That could take till the end of the year. QAF 8 runs into next year, so we've got some overlap, hopefully. We're hoping that QAF 9 will be as big or bigger than QAF 8 will be, but we don't know. It's so many unknowns. So best sports, my sports analogies, right? Best defense is good offense. So our continuing strategic offensive positions continue to grow primary care. So we have Dr. Ralgo's practice that is adding new patients, have a significantly better payer mix in our primary care offices than we typically have coming to our hospitals. And we would continue to, hope that we can be a provider of choice for commercially insured individuals who live here in Pajaro Valley. And Dr. Rabago's office, we're adding a nurse practitioner within the next couple of months. So that will add to the capacity in that office. And like I've said before, we have more physical space in that office to be able to recruit additional providers there as well. So like I said, that will continue to strengthen commercial payer mix. We do have a slight upward trend over the last 2 years in commercial payer mix on the inpatient and the outpatient side. Kaiser hospitalists are doing a wonderful job of covering the hospital right now. We're hoping to finalize that agreement within the next couple of months. They're also talking about adding additional specialists to take care of more of their members here in our hospital, which is their hospital, northern Monterey counties. And continuing to strengthen that relationship so that we can, that helps both them and us. Measure N projects, Measure N funded projects will help us financially, particularly the ones that are here listed that'll happen in 2025. A new MRI machine will provide better throughput for our MRI scans. We'll have better capacity there just with one new machine, replacing the older machine with a newer machine. And adding a second CT scanner by the third quarter as well, which will double our CT scan capacity and eliminate any potential for CT scanner downtime. We also have some energy efficiency upgrade projects, solar panels, LED lights, things like that can be paid for through the bond money that will generate some pretty significant operational expense savings. The cardiac cath lab, we anticipate being able to do some diagnostic and interventional radiology procedures later in Q2, and then EPCI, elective percutaneous coronary interventions, as soon as we have a state to be able to do that. Our cardiologists are ready to do that. We'll be bringing in additional in-person intensivists to be able to work with those patients who need to stay overnight. And then just a number of additional, and I didn't want the font to get too small, but we've got others. We've got this list of initiatives. Senior leadership team just went through the whole list in our meeting yesterday, but this is a number of the key higher level things that we've got in the works for the next few months. So supply chain improvements, we have an emergency department pilot going on with a consultant who's doing some lean work to improve how we make sure that our nurses, doctors have everything that they need at their fingertips when they're taking care of patients. We've already realized, thanks to the finance team and the pharmacy team, Jen, realized savings on 340B, which is now approved for both the inpatient and the outpatient sides of our business, which is a great new benefit for being a nonprofit provider again. And the list goes on. I don't need to read them all. See them. A lot of really strong work by senior leadership team that's here in the room. Appreciate everybody and all the work that's going into to all these initiatives that we will be tracking closely. And as we have wins and progress. We'll bring more specific project progress updates to the board so you can keep an eye on that, hold us accountable to progress on these areas. Coming soon, I'll be doing a CEO AMA. So I think we got this scheduled for a week from tomorrow. So kind of reimagining the town hall style rather than me doing a PowerPoint presentation saying, you know, at the end, you know, any questions? We're just gonna do questions. There have been, I know that the board members are aware, we've had a number of staff members who have had fraudulent tax returns filed. So there's a lot of questions about that. So we've responded, we've sent out, we've provided credit monitoring, ID protection monitoring for all staff. We want that, and people still have questions, right? So we want to be able to get out there and answer questions that people might have. We want to keep doing the right things for our people and make sure that they have questions. There was also the American Hospitals Association sent out a memo to all hospitals saying, hey, there's been some terrorist threats specifically against hospitals and healthcare organizations. So we've sent that out to the staff, and we've talked about, you know, our security measures and what our policies are, our codes, code silvers and our yellows and all of those different codes that we have, and how can we answer questions that people have about those things, because those are some scary things and some unsettling things. So we want to make sure that we provide. So hopefully we'll get some good attendance, and they'll drill me with questions for an hour. Also coming soon is our State of the Hospital event. So that's coming up on April 18th. And hopefully you'll all be able to attend. We'll be having presentations by folks from our county health office, as well as our board chair, myself, and one of our directors who's helping us build up our cardiovascular service line to let the community know what kinds of things we're doing, what we're working on, talk about the financial state of the hospital and all of the big plans that we have. I'm sure we've got some nice materials to hand out at that the Hospital Foundation is helping us prepare. And this is just one really important step in us being transparent with our community and being open with our community as a community-owned asset. And I'm happy to take questions, and I know that Matt and Phyllis have other things to talk about and update you on, but take questions before that.
Any questions for Steve at this point? No? All right, quiet crowd today. Matt, whenever you're ready.
Thank you, Doug. Just a couple of things to touch on that Steve mentioned as well. Our radiology group, that PSA has been executed, so you'll see that next week, last month, we approved the parameters for that agreement. Steve mentioned the 340B program, and I just wanted to take a moment to thank Jennifer and her team. We rolled out the inpatient portion of 340B on March 11th. So very excited. There's been great achievements already on the outpatient side, and there's even more opportunity on the inpatient side. So we're very excited by getting that rolling in place. Earlier this month, the American Hospital Association had issued a terrorist threat bulletin informing hospitals that there was a post on X that talked about some planning of a potential targeting of healthcare organizations within the U.S. Today, there was an update to that bulletin. The FBI has done their investigation and review and have not identified any specific sources or credible sources for those threats. So they've pretty much backed off on that and stated that they would be continuing to follow, and if anything came up, they would be informing any entities that are at risk or through greater broadcast through the AHA. So good news, we had made a couple of changes at the facility related to access. And really we have COVID to thank for improved control of access. Prior to COVID, we had 14 entrances into the hospital. We now have 2 regulated entrances. We're still looking to make some improvements. There's some challenges on the MOB side with access, but much improvement over where we were historically. Another thing, our EOC team, and Robin's in the audience there, they've been working with the county HCC to complete a hazard vulnerability assessment for our hospital, as well as the county-wide healthcare entities. Our top 3 items were staff shortages, communications, health invaders, and then multiple things for third, cyber attack, external fire. This is something that they were working on mid-year last year and was finalized by the county just recently. On the countywide HGA, the earthquake, fire, and communication was their top 3 threats. And then the combined hospital, combined hospital HVA identified supply chain, workplace violence, and staffing shortages, top 3 threats. So Robin and our EOC team will be working on just improving and enhancing the existing plans that we have to mitigate risks within those areas. But it's my remarks today.
Any questions for Matt on any of those items or?
Okay.
Are you ready?
All right. So just continuing to update on the palliative care team, we will be taking our first patient next month. So super excited about that. We are having some robust conversations regarding workflows and documentation templates. We have a physician leader, we have nurses, and we're hiring a social worker. So this is just a boon to the community and really delivering an excellent level of care. So super excited about that. Steve talked about workplace violence, super proud of that work. This is an employee-driven committee, and partnering with my co-chair Margaret, really great energy in that committee. We have already implemented some interventions to keep our nurses safe, because you saw the high number of employee injuries, and many of those are related to people lashing out, not necessarily maliciously, but because they are in a state where they aren't able to control themselves. So we'll be keeping that on your radar as well. One of the things that I wanted to bring forward is just, again, thanking Kaiser and helping us with the hospitalist contract. It has really stabilized our hospitalist medicine, and really appreciate the efforts of Dr. Clay Angelo, whom I think all of you know. And then the last thing I just wanted to report to this committee, and I'll be bringing updates. We are up to now 20 volunteers on our volunteer roster. So that is hugely different than what it was about 6 months ago. We have a really engaged leader, and we are talking about opening the cafe again for breakfast and special coffee. So very fun. So I'll be bringing more updates about that. April 28th is a celebration. We're going to be having just a little luncheon for our volunteers. April is volunteer month. So I would send this out to the board if any of you would like to come by and thank our volunteers. It's a gift of love that these people do this for our hospital. So I'd like to invite you to that on April 28th. And otherwise, that's it for me.
Any questions for either of these reports now that all 3 are questions?
Just some big picture questions. I guess maybe ask follow to the patients lashing out at staff. Kind of careful with somebody I'm not looking at it for a bit, like how much is influenced by acute crisis?
Some, and this is not unknown in healthcare, but if you follow any healthcare news, you hear about a lot of violence, and there's been a lot of gun violence, unfortunately, in hospitals. So violence could be any number of things, like verbal threats to actually people lashing out to people who are malicious in intent. Ours have not been necessarily malicious, but we have, increased mental health holds in the ED, and folks who are in a state of crisis and they're lashing out. We have folks with dementia who are otherwise not capable of managing themselves, who don't even know where they're at, and so they lash out. We're trying to provide care, and so we have a lightning bolt magnet that goes on the door jamb of the doors to alert anybody going into the proceed with caution, go on with another person, be aware this person may act impulsively. And so just trying to keep our patients safe, but also our staff safe. Nobody wants to come to work and be injured. And we've had people hit, kicked, punched, thrown things at. So it is a phenomenon that is not unknown in healthcare, but it seems to be hitting kind of a fever pitch. And so really trying to get awareness, first of all and foremost, using education, and then providing our staff with tools.
Follow-up question. So you just mentioned a couple of basic, obviously very general examples, but when you're looking at specific cases, are you looking at causation beyond like a common theme, I guess? If it's, for example, patients with dementia or patients with, mental health, we kind of know those areas, but what are commonalities of why they would lash out? space?
You know, and that's a great question. Some of the work that we're doing in the Workplace Violence Committee and with Robin's EOC team is kind of trying to bucket those so we can target interventions on that subset. So it's not all mental health patients, it's not all dementia
Right.
patients. Sometimes people are just angry.
Right.
And so, but really trying to understand because of different interventions for different groups of people. But the overarching theme, of course, is keeping our patients safe and our staff safe. And so we are definitely drilling down. We do call something called a code gray, which draws a show of force to the bedside so that we can, first off, manage the crisis, but then we track these diligently and drill down on each of these so that we understand what the commonality is, because sometimes the question is, could we have prevented this? Could we have gotten out in front of it? And so there's a lot of work to be done, and we've met a few times. This committee is relatively new. It had been sunsetted for a while post-pandemic. So we're really trying to get kind of like to your question, kind of the causality.
Yeah, it just came to mind, like sundowning in patients and length of stay, length of time, and how long they've been waiting for services or from, you know, those things can trigger inadvertence, you know, issues. So, okay, thank you.
Well, thanks for the question.
Any other questions? Okay, thank you so much. Move on to item number 8. Julie, the financial officer, monthly financial performance update.
Okay, as you saw from Steve's dashboard and some of the comments, we had a pretty difficult February and we've got a hole that we are digging ourselves out in. So I'm gonna go through the typical slides and add some additional commentary for some of the drill down that we've been doing to kind of understand causes and, you know, where we need to focus our energies. So this is the month of February, and you can generally see that the net operating revenue being, you know, about $3.5 million behind budget is the major driver of our problems. Most of the expenses, with the exception of pro fees, are within budget or pretty close to budget or even under budget. Pro fees, with all of the interim arrangements that we have going on right now, has added to the expenses there. And, you know, it's anticipated that will continue throughout the year because what we budgeted in anticipation of what we knew at the time of budget and what's playing out, you know, have some variances of their own. Next slide. So a little bit just to touch on the month over month impacts of net revenue. You know, besides comparing to budget, we just always kind of look at what changed month over month, because that really drives a lot of what goes on when we value the accounts receivable. We did have $14 million less in gross revenue in February than January, but remembering that February has 3 fewer days than January, it's actually kind of interesting because when you start to look at things on a per day basis, there's not as much variation as $14 million leads you to believe. And we did have a $3 million net revenue variance. Another part of January was when we were heavy into catching up charges on accounts that had been part of the cyber attack. And after we had registered those patients and had to go through adding charges, some of those charges from December and very end of November visits were actually placed on accounts in January. So they showed up as January revenue. That was about $3.5 million. So a little bit to the side that the January revenue was larger than normal for those reasons. We did see that we had 350 less visits on kind of total side. But again, as you look at a per day basis, it was 9 more per day than February or than January. And you can see, we look at things kind of looking for what's a service mix change, meaning that maybe patients are less acute or doing different services that don't have as high a charges. And then what's more of a payer mix shift. So, you know, on the gross revenue side, that kind of indicates a service mix. When on the net revenue side, it can be a combination of service mix and payer mix. And we've just done a lot of different drill down, trying to understand, which services we had less of. And I'll kind of touch on that in some of the upcoming slides. So before I get there, this is just what the year-to-date looks like, and you can see that we're, about $4 million unfavorable on the net revenue side and about $1 million favorable on the expense side. The challenge is when the net revenue falls, we can't always drop the expenses, equally because of staffing ratios and just kind of bare bones operations that we need to continue. With that being said, we are looking at, all of our staffing and, trying to understand if volumes are really dropping, we've got to do something differently all the way down to administrative staff where there may be, fewer people to flex off and lower volume and the work is still there, but just looking at, having flex people off for a few hours, for a day, something that helps us be able to afford knowing that we're going to have less revenue coming in the door for lower volume. Next slide. So from a statistics perspective, here, admissions, we're about 10 below budget, but we really saw revenues down kind of across the board in med-surg, pediatrics, ICU. In the peds volume in particular, because we did put a pause on the younger pediatric admissions, and we did have some of that peds volume in our budget, that plays a part there. The outpatient side has been down. As we mentioned before, cath lab not being open, we had budgeted that would be open in the first quarter of the year. And so we have some volumes and revenues and expenses that were budgeted in the first few months. We are incurring some of those expenses as we have, a director and staff, preparing to be able to open, to pass surveys, to finish the PCI application, get equipment, supplies ordered, and all that. On the ER side, while the ER has been busy, and you can see that ER visits actually exceeded budget by 25, just looking at the mix of acuity, the different levels of ER visits, they're tending to be a little heavier weighting on the lower acuity visits, and thus lower charges for those visits. Our surgical revenues are down. I'll show you some surgical slides, the normal slides in a bit. Not terribly down, but sometimes again, you can have a mix of services that also plays a role. And then we were below budget on the radiology and rehab volumes for the month. And again, radiology, we've had some, challenges with downtime with equipment, with staffing, that have contributed to that. Next slide. So it's really kind of an interesting phenomenon that I just told you all the things that were down or not quite meeting budget, but a lot of those things still represent an increase over where we were last year. So our inpatient volumes, as you compare them year-to-date versus February year-to-date of 24, they're up 11%. They're only below budget now because we don't have all of our initiatives fully implemented. Deliveries, and I've got a nice slide to show you how deliveries have continued to grow, and they're up 36% over where they were last year-to-date. And again, year-to-date being 2 months last year versus 2 months this year. Inpatient surgeries, 2%. And, this time last year was really when we were kind of working through, are we categorizing people appropriately inpatient versus outpatient? It was a lot of the work that we did in the early part of last year where we started to see that shift from inpatient to outpatient because we were better at identifying medical necessity and how they should be registered. Outpatient surgeries, they're down 19%, but last February was it was kind of a phenomenal February, especially for a short month. It was our highest surgeries of any month last year in the shortest month. So that, kind of sways it a little bit more than it'll probably normalize out over the coming months. the ER visits and other outpatient visits are both at 5% year to date. And we've seen that growing kind of month over month, as we just, been seeing the ER become busier and busier. Next slide. So here's what admissions looks like over the last 13 months. And so you can see that there is a slight upward trend, and most of the months are kind of within the same range, just incrementally moving up a few notches. And we've had, every so often, about every 3 or 4 or 5 months, we get kind of a real busy month, and then it tails back down to where it's been running. Next slide. I added this slide just a little bit to look at inpatient acuity a little closer. That's our case mix, and basically the measure of how ill our patients are. This is one of our revenue initiatives to make sure that as we work with physicians on proper documentation, that we're also capturing all of the comorbidities, all the conditions that might actually drive the patient's diagnosis to a higher level, which would result in higher reimbursement for us on the DRGs. We do audits every year, and in some of our audit from last year, it was pointed out that there's opportunities that we may have missed being able to move a patient to that higher level of acuity because of our documentation or something in our process. So it's an area of focus for us because it will drive higher revenues if we're actually get better at that. And you can see, pull out a couple of outliers. It looks like a pretty flat line because we had a couple of high months that can just be a couple of really extreme cases. It doesn't take many cases to move that needle. But if you drop those out and you look kind of from about August forward, you can see we are kind of creeping up. So I think some of this work is, potentially starting to take hold. It's a slow moving metric, especially because the population of the types of DRGs we see is pretty consistent every month. And they kind of tend to be in the same relative weight range. Next slide. Here's our average daily census. So while we feel like we're always kind of behind budget, but lower than budget, because we have been lower than budget for a number of months, you can see that over that course of that 13 months, we've actually been creeping upwards, kind of consistent with the admissions. The other piece here is that we've been very strong on the length of stay. We've actually been lower in length of stay. So that kind of detracts from daily census, but that's appropriate because we're not going to be paid for length of stay that don't meet medical necessity. 5. Outpatient ED visits, the blue is the ER visits, the orange is the other outpatient visits. This shows the ED is relatively flat, but it's been a busy, probably average about 98 patients in most months. And then the orange, the non-ED outpatients, they have been generally moving upwards, very subject sometimes to situations with equipment failures or with staffing, where we might have to reschedule a patient. And we've certainly seen some of that, which is why we have a couple of measure and initiatives to help resolve that. Next slide. So here's the bright spot in looking at how deliveries have just really, been moving since like last June. The last high month we had May was pretty high. February is just a little bit higher. Again, 3 fewer days and more deliveries. So February was definitely a busy month, but it's a nice upward trend over the last, 8 or so months in the right direction. So total surgeries, the green at the bottom is the inpatient surgeries, the blue is the outpatient surgeries. It was a lower month in February, but not really out of the norm. And I think if we hadn't had such a busy last February, this would look even less volatile. The inpatient surgeries, we did 40 this month, and that think we had budgeted 36, so we were actually meeting our budget on the inpatient and just a little bit low on the outpatient. And here's really where not having the cath lab open impacts that outpatient, because all the volume that we had budgeted for the cath lab this year is outpatient volume. Next slide. Payer mix, really what we saw, and this does have a significant impact on the net revenue for the month, was that our commercial mix, just compared to January, declined by about 4%, and our managed Medi-Cal increased by about 4%. Everything else was relatively flat. And you know what that represents in terms of reimbursement is about a 10% difference. So you get 10 cents more on the dollar for every commercial patient than we're going to get for a managed Medi-Cal patient. So that sort of shift on the amount of volume we have, you know, can be a $3 million swing. Next slide. The outpatient, relatively flat, you know, fairly unremarkable. There's a little bit of an increase this month, 1%, in the Medicare, and the offsets were kind of sprinkled throughout, mostly between commercial being down about 0.5% and managed Medi-Cal being up about or down about 0.2%. So before I move on, I just want to pause a minute because I'm going to talk about some other activities. Some of it is a little bit repetitive to what Steve mentioned, but wanted to know if there was any questions on the actual financials.
Two questions. One, do we have a best status on the cath lab and when it might reopen? Maybe that's not you, but the other one is if you could roll back to the slide on case mix index, or maybe just talk about we're rating the ratio as 1.2, 1.3, 1.4. Where did that ratio represent? I understand we're measuring the illness patient, but what is the 1. What does the 1.4 mean?
Well, every DRG, diagnosis related group, has a relative weight. And so what you do is some relative weights are greater than 1, they can be greater than 5. Most of ours, you know, probably tend to be on the lower side, not necessarily, you know, we don't have super complex cases that are very highly weighted. And if we do, you don't have a lot of them. On the other side, you can have relative weights that are below 1, so 0.8, 0.9. And that calculation basically takes, you know, all the cases you did that month, adds up all the relative weights, divides it by the number of discharges. And so it's basically saying kind of what's, you know, where do you line up? You know, if 1 is kind of the start point.
Yeah.
And so it's really is a measure of, you know, you have more higher level cases, lower level cases, you know, what's that mix? And, you know, a lot of our cases are sepsis cases. We have a high number of sepsis cases, and within the DRG family, there's 3 different levels of sepsis, you know, from the kind of general sepsis to a much more complex comorbidities and complications. You know, we tend to be in the more general cases, but this is where we have opportunities to make sure we're identifying all the comorbidities, the complexities, and that we're coding and documenting to the level that might move us to a higher DRG and then reap a higher reimbursement. I'm on the cath lab. I think we're targeting middle of April to try to have our first elective case in there. We're still not to the point of, we've got the PCI application has been submitted. We still have to go through a survey there, but we're basically doing the supply ordering and some equipment ordering to ready ourselves for about a mid-April.
Yeah, well, that's very optimistic. So I think because we have some contingencies, and 2 of them are really important pieces of equipment that we recently got signed for. So it's foundation funded, very expensive piece of equipment. So a huge thanks to June and the foundation. Another one that it's a Zoll monitor, the defibrillator. So there are some key pieces of equipment that we cannot open without. So those are things that are contingency. So right now we're doing staff training. working on workflows, meeting with cardiologists and staff. So there's just a lot to get this right, and it's really important to get it right. Patient selection in first case is key. We do not want to ever have a failure or any kind of misstep. So we're going to be tracking with an overabundance of caution. But as soon as we can, we're going to.
For the survey, is it a matter of us not being at the front of the line and waiting as well too, or?
So actually, no, we submitted the application on Valentine's Day with little red hearts on the FedEx envelope. And we heard already from the state. So it went through the first tier of approval. And so now it's in the hands of a medical team. It's actually a physician and a team who will come out and survey us. So it is getting in queue, but we are definitely on their radar. And the physician already has a relationship with Jerry Souza, our director. And so they're having conversations. So we want to make sure, because when they come, we want to be fully ready. And that means we have to have all of our workflows, our equipment, and our staff. So that's kind of a parallel path, because we can do first diagnostic case before the survey, but we need to be survey ready, because the survey is what allows us to do the super fancy interventional stuff, which that cath lab is prepared to do.
Any other questions? No? Julie, I had a question about the payer mix within the deliveries that are happening at the hospital. Is it mostly Salud Gente, Medi-Cal mix? Do we know?
I don't have those specific numbers, but I would generally believe it would be a lot.
10%.
10% Kaiser? Oh, interesting. Okay, is that
On average.
okay? I was gonna say uptick from month to month or year to year, or
It's generally trending a little bit down, like it was 13, 11, 10. Then it'll go to 9, then it'll go to 11.
interesting.
I
Okay.
have all, I can email it to you.
Yeah, it'd be great. I'd love to take a look at that. Any other questions before Julie moves on? Go ahead.
Okay, I have one more slide here, and you've already heard the best news, which is the top bullet that says our loan modification was approved, 12-month deferral, so that gives us a $1.8 million impact, which, you know, then we could reinvest in some of our other expenses and getting our programs running. The dish cuts, they have been postponed to at least October. We're hopeful that maybe that will even go longer, another postponement. They've been postponed over and over again for a long time. But since we do receive most of our dish payments prior to October, that really means that that money will be in our pocket. And we had kind of gone into the year with such uncertainty that we were, you know, really only kind of counting on maybe seeing about half of what the dish payment could be. And so now with this news, that should give us about $800,000 more than our conservative look was. The Quad 9 model, as Steve mentioned, is due to be sent to CMS by next Monday. And once it's sent to CMS, that should make visible what they're targeting, looking at doing with that model. Because we have, the rumor mill says it should be better, but we didn't have any data or anything to look at. And, you know, there is expectations that it should be higher, but there's also expectations that it'll probably undergo more scrutiny than maybe even normal. Definitely additional scrutiny. And so that'll probably mean the approval will take longer. And, you know, I think the last program, the approval took a little bit longer than expected, which really just, you know, the program finally came out, FOP 8 came out, you know, and it had some nice increases in it. It just didn't start as soon. And, you know, we have a pretty heavy reliance on those directed FOP payments, and sometimes in between, because the directed ones come about twice a year, and sometimes in between is really, you know, our tightest moments in cash. So, you know, we want that to be good news, approved as soon as possible and get the program started. But as Steve also mentioned, we still have FOP 8 and that program actually runs into 26. And it is, you know, past programs have had overlap where you're finishing off one program and starting up another. And that for us is kind of an ideal situation. And then the last point I want to make, and this is my last slide, is just, you know, we're working hard on reducing our accounts payable backlog. We still have it. We did have a good month from a cash collection standpoint, in March. Actually, February, we got a big Medicare payment the last day of February. Sometimes I forget I'm still talking February. But, I'm also giving you a preview that March's cash collections have been better, so we've been able to make more payments than, you know, kind of those lowest months when our cash collections were so low. But we do still have a backlog and quite a bit to work off. So we're continuing our work there. That's the end. Take any other questions?
Any other questions for Julie? Julie, I had a question. It was from a meeting in January, if you can remember back then. We had the federal government came in and I think took money that they had said that from the previous owners. Do you know what I'm kind of talking about?
Well, yeah, we've got, that might have been the recoupment.
Right,
Because
yeah.
there was an audit of,
Right.
on one of our cost reports that did require that they did take back, and for us, the timing couldn't have been
Couldn't have been
worse.
worse, right, yeah. Have we looked into anything of trying to get that money back and understand, because from my understanding is there was no negotiation, it was just like hey, we saw this and we're gonna take it now. And
Yeah,
just-
there is no negotiation in
Sure.
terms of, and we do have, the revenue cycle team looking, because this is related to how we report, bad debts. It's got
Right.
the Medicare bad debt on the
Mhm.
cost report. And there was definitely some things that were reported erroneously, and so the take back was warranted.
Mhm.
But there's always also an opportunity to kind of go re-scrub the data, and the revenue cycle team, along with Guidehouse, our
Mhm.
vendor, is tasked with, take another look at that data and see if they're, if we won't recover the whole thing.
Right.
Recovering any of it
Any
would
of it
be
would be, yeah.
valuable. It's a kind of a painstaking process to
And-
go through it, because they're going through at the kind of account level.
Mhm.
Lot of accounts, but, so it's work that's being done kind of in between.
The
other
pecking,
work
on
as
the
well.
pecking order, I'm sure it's not near the top, right?
Yeah.
Yeah.
So, it's kind of not one of those things I count on. If we get some back, it'll be a nice,
Ton of money.
positive. I think the piece that had also really hurt us right at the same time of the cyber attack was the fact that we had an NPI enrollment issue, the National Provider Identifier with Medicare, and they just kind of stopped sending us payments, and that volume increased quite
Right.
heavy, and that hurt us a lot. So we have received a lot of that. I think there's still some more of that money out there, but that was the big payment that we got on the last day of February, and we continue in March to see some of those payments coming in.
Okay.
That's been very helpful.
And then from an impact on just day to day, and maybe a question from Stephen Macklin too, like what does the 12-month deferral look like for us? Like what is that in terms of breathing room, or in terms of allowing us to do, or any of these things?
I mean, honestly,
Yeah.
it'll go towards the AP backlog. I
Okay.
mean, it's about $150,000 a
That we
month,
have budgeted, right?
Pardon?
That we had budgeted into this year in terms of making payments on, or?
I have it in my cash forecast,
Sure.
so I'll be able to say, well, instead of that 150 going to, the state for that payment, it'll go to one of our many vendors for one or more payments or a partial payment.
Okay.
The 1.8 million, I mean, I'd rather be able to put that in
Right.
AP backlog than have
Yes.
that continue to grow, but,
Mhm.
actually, that's like where it's gonna end up.
So, the 30-month, that's the new time schedule, remind me?
What they originally did, it was a 72-month loan originally with 18 months of grace period.
Right.
So what they've done is they've now made it an 80-month loan with 30 months of grace period.
Okay.
So at this point, we were set to do our first payment on May 1st of 25. If nothing else changes, our first payment is now May 1st of 26.
I see.
But they have, in the loan modification application, they mentioned a second, kind of bite at the apple, which is first you have to go get approved here. And then at some point, we'll open up a second application process, either for further deferral or for potential
Forgiveness.
forgiveness. So they were a little, they didn't really spell out for sure which way they were gonna go on that. But your first step was, the first hurdle was you had to be approved for this. So we've met that first.
Do we know, and if we're the only, I'm sure we're not the only one who probably applied for this, but.
We were told we were first. We don't know. We don't know if they're around.
I'm sure there were.
Yeah, I'm sure there were, what was it, 17 hospitals throughout the state, is that right? That applied for the loan. I'm just wondering if there's a way that we can advocate together or if that advocacy is already happening for all the applicants of, I know we're gonna do this already, but, just trying to grease that wheel, I suppose, of talking to our state legislature and understanding the budget constraints that they're already under with everything that's happening at the federal government and the situation with Medi-Cal. Obviously, I'm sure you have all read the headlines in the news of what's happening with Medi-Cal right now, but and just getting out in front of that, I keep thinking about what a difference this would make getting this loan completely forgiven for our strategic outlook.
It would be, we've had that conversation with our electeds as we see them. And we'll keep going through the process that, keep jumping through the hoops that they ask us to jump through. And if any of those hoops get unreasonable or look like they're leading to no's, definitely ramp up the advocacy. But for now, we seem to be on track with that process. Yeah.
Any other questions for Julie? No?
Just comment before we close this item, get gratitude and appreciation to your entire team. Got a chance to meet one of your newer staff. I'm grateful to see you responding to those long overdue vacancies. It's been a long, hard 3-4 months. I think we all recognize that. And the stress that's happening at the federal level, man, we're $11.1 billion that are going back to COVID-19 public health funding. States. I appreciate your open comments at the beginning of this meeting. It's just a time of great stress and uncertainty for especially our populations who are most in need. Serve and be served proudly with a smile. So I just appreciate the work. I appreciate the ongoing challenges and the level at which the staff collectively is working through it, through the noise, keep moving forward and recognizing also the creativity or the thoughtfulness about not just reacting, but being proactive. What might we do if these down months continue? So they're there, yeah, but I appreciate that we're already thinking about those levers that we have to practically manage that. Thank you.
Actually. Okay, well now, I need to ask public comment for this. Does everyone wish to speak in public? I don't see anyone joining with us online. Anyone wishing to speak on this item in person? Seeing none, I'll close down the public comment and move us on to item number 9. It's the Watsonville Community Hospital Quality Report for March 2025. Mike, whenever you're ready.
Excuse me, Megan, thank you for the opportunity to present to you today. And so for my first report as your official director of quality since at the end of January, I want to bring to you the regulatory update. Next slide, please. We did have a CDPH surveyor show up on February 12th at our facility for a CDPH complaint validation survey. The surveyor stayed on site until the 25th, which was an extremely lengthy survey. We had 10 incidents, facility reported incidents that were evaluated by the surveyor. 7 were pressure injury self-reports from dating back to 2023. 1 was a patient fall with injury that occurred in January of this year. 1 death in restraints from the previous year, 2024, and 1 abuse allegation from 2022. Additionally, during that survey, CT scanner and MRI caused diagnostic issues, and we had 2 complaints that were presented to CDPH regarding our service disruption. On March 10th, the 2567, which is the statement of deficiencies from CMS, was received. We did not have to submit any plan of correction. However, they did appreciate 1 single standard deficiency, which did not rise to the level of conditional participation. That deficiency was identified under nursing services and patient care planning. Next slide, please. This slide explains and reviews the healthcare required conditions over the past 2 years. So for calendar year 2023, unfortunately, the data elements are not necessarily aligned as they should be with 2024 and 2025. And so the definitions were aligned as to how only the reportable incidents presented to the CEO or the dashboard, as well as to the board of directors. So far this year, we've had 1 fall with injury, which is already an improvement. However, the year is still young. We've had only 1 case of C. diff as a healthcare acquired infection, which is a net improvement over previous years. So last year we finished with 6 C. diff infections. The last one in 2024 dated back to May, so we had significant improvement there. So far here today, we have 2 healthcare acquired condition with an annualized projection of 12 if the rate was constant, which is already an improvement on the 15 that we had on the previous year. You also have a breakdown on the graph with the falls, the healthcare acquired pressure injuries, Clostridium difficile cases, central line associated bloodstream infections, catheter associated urinary tract infections, surgical site infections, and lastly, the year-to-date cumulative. The first bar is the 2023, second bar is 2024, and 2025 year-to-date is the third bar on each of those categories. Next slide, please. I have located on the Healthcare Quality Improvement Platform Analytics is the organization which collects all of this data for us and presents it nicely in these graphs. And so here you have the hospital-wide readmission. The first pair of bars represents 30-day hospital-wide readmission for unplanned admissions. So we are looking ourselves in blue at 9.9, while California-wide average is 12.3. We are below that average. And for reference, we also have the 14.7 daily admission rates, which all show lower than the state average, with the exception of the 3-day readmission rate, which is very near at 1.3 and 1.5%. To be of note, this data represents the entire 2020 year up to the end of 2024. Next slide, please. Again, from Healthcare Quality Improvement Platform Analytics. Here we have the principal diagnosis and mortality rate per 1,000 patient trend. Again, this data is for that 4-year period, which I mentioned. Watsonville Community Hospital finds itself at 17.6, while the state average is 22.4. Next slide, please. And lastly, seeing it as a huge focus for our organization, I have located the top social determinants of health, which are present in our organization. And so here we have those listed. The first paragraph of bars is the housing and economic insecurity. The second pair is intentional medication underdosing. The third pair is history of falling. The fourth and fifth are unsheltered and sheltered homelessness. And the last 2 pairs are allergies. The first one being like allergy. And last slide, please. So with the initiatives for the first quarter, we've been extremely busy. We have been creating a number of work groups and collaborating with the other departments within the organization. And so we've identified a few concerns with our press-gain HCAPs, which we are drilling into, and making sure that they're improving and getting the market, getting all those surveys in so we can improve the quality of care in our organization with surveys. We've also been working hard in the home medication list work group, which has been proving a challenge due to the nature of our EHR. So we've been working with physicians and leadership within the organization to get this process dialed in so that we can ensure that the patients have solid medication lists upon admission and have that available on discharge as well. We've been diligently, having our weekly healthcare acquired condition work group, where every week we review and do a root cause analysis of the incidents that occurred in the previous week. We are working with our new data abstractor to create the public-facing quality department SharePoint site for the organization to click on and review their own data and just participate with that data. We have been working very hard on implementing MD-Stat and ND-Stat, which is a medical staff office management software, which will help us with our ongoing professional practice evaluation as well as credentialing and all of that, which is attached to the medical staff office. We are very excited about this collaboration with our new medical staff director, and we have been having a few incidents that we are working on and working on solid action plans so that Thank you. I'm happy to take any questions.
Any questions for Michael?
If you go back a few slides, the first one is comparing us to the state, big blue charts.
Readmissions.
I would just, the font a little small, so I was trying to understand who was us,
And so,
bring to state average.
Yes.
Yeah.
and I will get
Lower is
these
better.
slides.
Yeah,
I will
lower is
have to
better.
make sure that
That's-
it is more
that's also-
clearly written. Thanks.
This is a good, it's just a good narrative. Yeah. Great, thank you.
Of course.
Any other questions? Okay, I do have to go off for public comment, or unless there's anything else you wanted to add before, okay. Rosie, any raised hands or anyone in attendance online?
No one online at all.
Okay, anyone wishing to speak on this? Okay, seeing none, thank you, Michael.
Thank you, Michael.
And that would conclude our regular scheduled meeting for the healthcare, or I'm sorry, for the hospital corporation.